I'm sorry, that should say speaker introduction. I have the pleasure of introducing our speaker today, Dr. Danielle Anderson. She received her medical degree from the University of South Carolina School of Medicine in Columbia, South Carolina. She completed her family medicine residency in the University of Kentucky Rural Tract, spending her last 2 years of residency at St. Clair Healthcare in Moorhead, Kentucky. She is board certified family medicine physician. She completed her addiction medicine fellowship in the Department of Psychiatry at the University of Kentucky, where she now works as an assistant professor and works full-time as an addiction specialist. So welcome, Dr. Anderson. Yes.
Okay. And if you don't mind, John, helping to monitor the chat in case we have any questions, if it arises, I'm happy to answer as we go along or at the end. Just going to put up our practice gaps for y'all to take a look at. You'll be able to receive a copy of the slides later if you want to look at those practice gaps. And our learning objectives are to identify common stimulants, their pharmacologic action, and current trends in stimulant use. We're going to explain the impact of co-occurring stimulant use and opioid use, and then explain treatment options for stimulant use disorder, including medications, behavioral interventions, treatment, and harm reduction approaches. Outline for today's talk. First, we'll talk about the stimulant types, again, their pharmacologic action, what acute intoxication with stimulants and withdrawal looks like. We're going to talk about the trends in stimulant use and impact of co-occurring use. And then at the end, we'll talk about treatment of stimulant use disorder. So this is a little bit of an overview of stimulants. Stimulants are a drug class that act in the central and peripheral nervous system. And dopamine is a neurotransmitter that's involved in stimulant use. And dopamine is involved in a lot of different functions in the body, including motor control, cognitive function, motivation, and reward. And as we'll see in a minute, there are many drugs that have stimulant properties. Stimulants generally work by increasing levels of dopamine and another neurotransmitter called norepinephrine in the brain. Some of the stimulants come from plants, such as cocaine from the coca plant, ephedrine from the ephedra plant, and cathinones from the khat plant. And then some are semi-synthetic stimulants, such as methamphetamine, that are man-made. Stimulants are legal. Some stimulants are legal and have medicinal use. Even cocaine, methamphetamine are uncommonly used to treat ADHD. So we often think of methamphetamine and cocaine when we are talking about stimulants, but we frequently encounter stimulants in over-the-counter medications and medications to treat ADHD. So now we'll look at stimulants by schedules under the Controlled Substance Act. So Schedule I drugs have a high potential for abuse and currently have no accepted medicinal use in the US. And those include khat, MDMA, also known as ecstasy or Molly, and bath salts. Schedule II drugs typically have a high potential for abuse, but typically have a current accepted medicinal use. But we do know that Schedule II substances can lead to abuse, also psychological and physiological dependence. Some of the Schedule II stimulants are cocaine, which is sometimes used as an anesthetic for oral procedures. Methamphetamine is uncommonly used to treat ADHD. Then we have amphetamine salts, methylphenidate, and lisdexamfetamine, which also are used to treat ADHD. Schedule III drugs have less potential for abuse. They usually have an accepted medical use and a lower likelihood of physical dependence. Over-the-counter stimulant you might see is phenylephrine, which is one of the nasal decongestants that people use. Typically can get over the counter. And the phenylephrine, you don't have to, unlike the pseudoephedrine that people use in Sudafed where we have to get that over the counter, phenylephrine does not require license. So I just wanted to find out how you feel about stimulants in your community? Are you worried about stimulant use in your community? And I think John's going to put up a poll for us. So it sounds like the majority of people here today are worried about stimulant use in their community, whether it be cocaine, methamphetamine, or maybe it's possible you have concerns about prescription medications for ADHD being able to be available for purchase. So we're just gonna, knowing that, we're gonna go forward. Before we move on to the next slide, does anybody want to mention what their concerns are about stimulant use? You feel free to unmute yourself or put something in the chat.
So from just in the hospital perspective, we're seeing a lot of people just with worsening mental health connected with their stimulant use, extended hospital stays, difficulty having a healthy, safe discharge, plain discharge disposition. I mean, I've been doing this for like a decade plus, and the last few years have been nasty. It just has not been. I don't know what other people's experience has been, but I've seen people come in sicker than I had in quite some time, and that's been scary for me.
Absolutely, Matt. Thank you for sharing. And as we're going to see in the next few sections, the hospitalizations involving amphetamines, methamphetamines, cocaine are actually on the rise. And you're kind of seeing that anecdotally, it sounds like.
There's a few things in the chat that I can read. People concerned about stimulant use in Boyd. Someone mentioned overamping with stimulant use, lack of treatment options. People are switching in a community from to stimulants because from opioids. Let's see, long-term paranoia, psychosis, cannot reverse with Narcan.
Absolutely, a huge concern that we don't have a reversal agent when people overdose on stimulants. And I have also a study we'll look at a little bit later about patients switching, actually using stimulants and opioids at the same time. But it's not uncommon in my line of work where patients are coming in, and when they have not been able to get an opioid that they prefer, they'll move to stimulants or vice versa. And they're absolutely, Candy says, the self-harm people do, their psychosis, their skin picking, there's risk of developing with IV drug use, endocarditis. So it is a really big problem. And absolutely, Shirley, people are mixing fentanyl with stimulants, and it's very scary and increases risk of overdose. So thank you, everybody, for sharing. Okay, we're going on to the next slide. Before we move on to talk about diagnosis of stimulant use disorders, I want to take a minute to talk about the diagnosis of stimulant use disorders. If you've been to KY Open before, you may have seen this slide that talks about the criteria for diagnosing someone with a substance use disorder. I just want to highlight the criteria we use to diagnose stimulant use disorder, which is the same as other substance use disorders. To meet criteria for a stimulant use disorder, you must have 2 or more of the following 11 criteria over the past month. And when someone develops a use disorder, that's typically means that they've lost control over their use. And what we might see is that people may fail to fulfill responsibilities, use in physically hazardous situations like driving. They may develop craving or have difficulty with social and interpersonal problems. Many people will start using in larger amounts over a longer period than intended, will not have the ability to cut down on their own, and increase the time they spend using or recovering from stimulants. They'll give up other important parts of their life to take care of their stimulant use disorder. They'll continue to use despite seeing a lot of these problems, and they may develop tolerance or withdrawal. So 2 commonly abused stimulants are methamphetamine and cocaine. So I wanted to take a minute to compare these two. Both are Schedule II drugs, meaning they have abuse potential and limited medical use. Methamphetamine, as we stated before, uncommonly used to treat ADHD and narcolepsy, and cocaine can be used as an anesthetic. Cocaine is derived from the coca plant, while methamphetamine is synthetically made. from easily accessed hazardous chemicals like nasal decongestants, ammonia that we find in fertilizer, ether, lithium, different household chemicals that we may see. The half-life for methamphetamine is much longer than cocaine, and a half-life is the amount of time it takes for half of the ingested substance to be removed from the body. Methamphetamine has a long half-life, so the effects are longer, while the half-life of cocaine and effects of cocaine are much shorter. Effects of stimulants on the brain. So we're going to talk about how these stimulants work. Dopamine is a neurotransmitter I mentioned before. It's released during pleasurable situations. For example, it's normal. Dopamine release is normal. Dopamine release occurs when we eat or have sex or play video games. Dopamine is also involved in the reward pathway which drives the continued use of substances. So let's take a look at how stimulants work in the brain at the level of neurons. Dopamine is typically released from the presynaptic neuron, which is these neurons on the left, into the synapse when something pleasurable happens. And then it interacts with this receptor on the other side, on the postsynaptic neuron. Dopamine is then taken back up into a storage area in the presynaptic neuron by the dopamine transporter. Cocaine blocks this reuptake transporter, leaving dopamine in the synapse to interact with the receptors for a longer period of time. Methamphetamine works a little differently by causing an increase in the dopamine release, which increases the amount and frequency that dopamine interacts with the receptors. Once we get this interaction with the receptors, all of the physiological and psychological effects happen after we get that receptor filled with the dopamine. So this chart kind of helps explain how much dopamine release occurs in the body. Again, this is a normal, natural part of our brain's function. And so if our baseline dopamine is about 100%, when we eat, play video games, or have sex, we may get up to 200% of our normal baseline. But when we're using stimulants such as cocaine, amphetamine, or methamphetamine, we see that this increases to 1,000 or 1,300%. So much, much greater, several times greater than just these normal daily activities. As we saw on the previous slide, stimulants cause dopamine release that is much higher than the levels that occur in our typical activities. It's this increase that leads to the acute effects of stimulant intoxication, which can be euphoria or a very pleasurable feeling, increased energy, increased alertness, increased social ability, a decreased need for sleep or inability to fall asleep, and a decreased appetite. When we get this large dopamine release, the reward pathway is reinforced. Okay. Acute stimulant intoxication. Here's some medical effects and the complications. So a person who's acutely intoxicated with methamphetamine may have dilated pupils. They may be hyperventilating, have elevated blood pressure or high heart rate, be very agitated, have symptoms of psychosis or hallucinate. And then there are also life-threatening complications. And I think this is something we don't think of as often. Maybe Matt sees this more working in the hospital, but sometimes those of us who don't see people acutely intoxicated may not really focus on these things. But there are life-threatening complications that can occur from stimulant use, such as seizure, cardiac arrhythmia, hypertensive emergency, a heart attack, stroke, breakdown of muscles, an acute asthma exacerbation. So rise in the neurotransmitter dopamine can cause all of these life-threatening complications. And as someone recently mentioned in the chat, there is no stimulant reversal agent.
Dr. Anderson, I think we just had one quick question.
Mm-hmm.
I think it's in reference to the previous slide about dopamine. Do opioids do the same, or is that why people mix opioids with methamphetamine?
So It's an interesting question. We know that this dopamine reward pathway is involved in almost every type of addiction. Opioids work via the opioid receptor, but there still is some dopamine release or feeling good that people tend to feel, and that's why that reward pathway gets reinforced. But these specific stimulants work directly on dopamine instead of via another action. So this study by Winkelman et al. Looked at amphetamine-related hospitalizations from 2003 to 2015. And just a note in this study, the amphetamine-related hospitalizations included methamphetamine use. Then when we look at this, we see from 2008 to 2015, there was a 270% increase in hospitalizations related to amphetamines. So what does stimulant withdrawal look like? Patients in withdrawal from stimulant use often use the term crashing, and may sleep most of the day for the first several days. Sometimes they miss meals. It's not uncommon for patients withdrawing from stimulants to have suicidal ideation. There's no medication that's really been found clinically effective to treat withdrawal. There have been a couple studies using modafinil, which is a medication that can be used for shift work or narcolepsy for stimulant use withdrawal, but this was found to be no better than placebo. Facilities that offer medically managed withdrawal will often stress the importance of sleep and hydration. So what we expect to see is someone being very, very tired. They may have increased anxiety, worsening depression, fatigue, extreme fatigue at times, difficulty concentrating. They may just experience anhedonia where they're not able to have pleasurable experiences. Appetite may be increased, and they may also have panic attacks. This duration, anecdotally, when I have worked with patients in the inpatient setting withdrawing, some of the worst withdrawal tends to happen in the first few days, but this duration can last 1 to 2 weeks. And again, we want to encourage sleep. Many of these people haven't slept in days, and we need sleep, body to heal, encourage fluids, meals, and supportive care. So just to recap, there are a variety of medications with stimulant properties. Acute stimulant intoxication can cause euphoria, increased wakefulness, increased energy levels, but can also have life-threatening complications. While stimulant withdrawal results in hypersomnolence or being very, very tired, increased anxiety, and decreased energy levels. In the next section, we're going to use this term stimulant and psychostimulant interchangeably because some of the studies refer to stimulants as psychostimulants. So we have another polling question. What is true regarding stimulants and overdose? Overdoses involving stimulants rarely occur. Overdoses involving opioids are increasing, but overdoses involving stimulants are decreasing. Naloxone can reverse stimulant overdose, or overdose deaths involving stimulants and opioids are on the rise. So it looks like most people are correctly identifying that overdose deaths involving stimulants and opioids are on the rise. Overdoses involving opioids are increasing. Overdoses involving stimulants are also increasing, stimulants alone and stimulants plus opioids. And then just remember that naloxone is the medication that can reverse opioid overdose, but there is no medication that can reverse a stimulant overdose. Okay. So stimulant use trends. Binge and crash method is a current pattern of use that's popular, and this occurs when people are continually using methamphetamines for days, oftentimes staying awake for days at a time, and then having that crash period we talked about afterwards with withdrawal. Another common trend is using methamphetamine and cocaine with opioids, and this is known as speedballing. We know that overdose deaths involving stimulants are on the rise. It's typically methamphetamine with other substances, in combination with other substances, such as opioids like fentanyl or fentanyl analogs. Pandemic did have an increase in the effect of on substance use. And by June 2020, we know that 13.3% of Americans had started or increased their substance use. So again, some more information on stimulant use trends. In 2020, 2.5 million people ages 12 and over reported methamphetamine use, with 53% of these patients or of these people in the population using methamphetamine met criteria for stimulant use disorder, but less than 1 out of 3 received treatment. Most people who use methamphetamine are between 25 and 54 years old. Recent data has looked at ethnic disparities in overdose deaths, with American Indian and Alaska Native population being the most effective by overdose deaths. The white non-Hispanic population falling second. Hispanic and Black populations, the overdose deaths are below the national average, but the US average overdose death rate has increased across all ethnic groups since 2011. So the use of opioids and stimulants, as some of you identified in the chat, is a growing problem. Methamphetamine use among those seeking treatment for primary heroin use increased from 2.1% in 2008 to 12.4% in 2017. So more people who are coming in to be treated for opioid use disorder are also now looking for treatment for methamphetamines. The number of overdose deaths involving stimulants and opioids are rising. In 2017, close to 75% of those cocaine-involved deaths and roughly half of the other psychostimulant-involved deaths involved at least one opioid. So again, we're seeing that same trend where people are using both, and it's increasing risk. And we'll take a look at a few studies that demonstrate this. So this study looked at rates of overdose deaths from stimulants from the years 2003 to 2017 and compared those involving opioids to those without opioids. Psychostimulant overdose deaths were stable until about 2010. Then we start seeing an increase in overdose involving stimulants with opioids from 2010 to 2015. The largest increase, however, occurred between 2015 and 2017 for stimulant use involving any opioids. There was a 50% increase annually. When we were looking at stimulant overdose deaths without any opioids, those were on the rise in 2008 and saw about a 22% increase annually up to 2017. So what I want you to take away from this is that all stimulant overdose with opioids and without opioids have really been increasing since the early 2000s. And here's just another chart highlighting, maybe a little simpler, highlighting information similar through 2020. There was a sharp increase in number of overdose deaths involving psychostimulants and synthetic opioids. Synthetic opioids, when we talk about synthetic opioids, typically in this case, a lot of times we're talking about fentanyl, which is not plant-derived, it's man-made. And that's what we're seeing. A lot of the overdose deaths are involving fentanyl and methamphetamine, as I think you're probably seeing in your communities. And here's another similar chart talking about cocaine overdose deaths. And we see the yellow line there is cocaine in combination with synthetic opioids, typically fentanyl, are really took off in 2016. So this is a growing problem that we've got to address in our communities. So we know from the last several slides that stimulant use saw an increase in 2019. And this chart shows overdose deaths reported by 24 states that participate in the state unintentional drug overdose reporting system. And this is just a big reporting system that's part of the CDC's Overdose to Data Action Program. Kentucky is one of those states, and this chart highlights the danger of using illicitly manufactured fentanyls, which are fentanyls that are not produced for medicinal purposes. These are typically manufactured overseas and are brought into the U.S. And that's what we mean when we say illicitly manufactured, not made by pharmaceutical companies for medicinal purposes. The overdose deaths involving the illicitly manufactured fentanyls and cocaine is higher than percentage of cocaine alone. And again, highlighting that there's a higher risk. There's a higher risk of overdose when we combine cocaine with an opioid instead of compared to just cocaine alone. So some researchers are calling this a twin epidemic of opioids and methamphetamines. This study was really interesting to me. It's done by Ellis et al. And at Washington University, and they surveyed persons seeking treatment for opioid use disorder about methamphetamine use. They studied motivations for using methamphetamine and opioids. Some of the 51% of the respondents mentioned that high seeking, they liked the high that they received from methamphetamines and opioids at the same time. 38% said that the balance of the effect, where stimulants are more of an upper and the opioids were bringing them back down. One patient wrote, "I use meth to give me a rush of energy and heroin to numb myself." Another person in this study wrote, "I was trying to get a lot of work done by taking the stimulants, but I didn't want to have pain, so I used the opioids." 15% are using it as an opioid substitute. 9.7% said they were trying to escape life or numbness. 9% cited addiction to various substances, and then social setting was at 6%. Participants in this study were also asked for explanations of the increase in methamphetamine use in their local areas. And the top 3 reasons for increased methamphetamine use that these patients or that the people in the study felt that methamphetamine use was increasing in their communities. The first was that there was increased accessibility. So 40% felt like there's more methamphetamine around, so people have more accessibility. 37.5% said that it's increasing in popularity. And then 30% said that that the methamphetamine is more cost effective to purchase than the opioids, and cited that as a reason why methamphetamine use is increasing in their community. So we spent some time talking about the increasing number of overdoses involving stimulants by themselves and stimulants involving opioids, and the loss of human life to these substances is tragic. So I think all of us here are in the business of hope. So I wanted to take an opportunity to discuss opportunities for intervention. This study, again, from the State Unintentional Drug Overdose Reporting System. This is data from the first 6 months of 2019, and in those 25 states that participated in this, there were over 16,236 overdoses. On the x-axis, we're going to see common circumstances surrounding fatal overdoses. A lot of times people have recently been released from an institution. There's a previous history of overdose, co-occurring mental illness, previous substance use disorder treatment, bystander present, and fatal drug use witnessed. And so in 60% of these 16,000 overdoses, at least one of these situations were present. And so all of those are a potential opportunity to act, a potential opportunity to provide education, to refer to treatment, to provide Narcan. And so while we hate to see this many overdoses, there is some hope here that more than half of the time we could provide some intervention that could be life-saving. So key points from this section are the number of overdose deaths involving stimulants have increased over the last 10 years, and really over the last 20 years. The number of overdose deaths involving stimulants and opioids have increased as well. Looking at non-fatal overdoses, we can find common opportunities for intervention. Now we're going to talk about the treatment of stimulant use disorder. And to date, unfortunately, there are no effective FDA-approved medications to treat stimulant use disorder. Treatment is individualized for stimulant use disorder and requires a comprehensive assessment. Patient-specific treatment plans may include off-label use of prescription medications, psychosocial counseling and behavioral interventions, and also harm reduction and overdose prevention. And so I think probably everyone here on KY Open today has a role in one of those three aspects of treatment. So here are the proposed mechanisms of treating stimulant use disorder with medications. And so there are multiple ways that we might develop drugs that could intervene in stimulant use disorder. And the first one would be to reduce or eliminate the euphoria or high from using stimulants, and thereby reducing the positive reinforcement. So when a person uses a stimulant, the high or euphoria that they experience will reinforce the behavior, meaning the good feeling that they get is the driver for the person to use that drug again to achieve the same positive effect. Another mechanism could be to reduce cravings that may predispose stimulant use, which is something that we see with buprenorphine for opioid use disorder. We reduce the cravings. Another mechanism is to reduce or eliminate stimulant withdrawal symptoms, and then we reduce our negative reinforcement. So when a person begins to have withdrawal symptoms after cessation of methamphetamine, the negative effects of withdrawal drive the person to use again to avoid feeling badly and stop the withdrawal. If we can find a medication that improves those withdrawal symptoms, we could decrease this negative reinforcement that leads people to repeated use. And then the other option would be to make stimulant use aversive with another medication. And an example, an analogy would be the medication disulfiram for alcohol, where it makes people sick if they use alcohol. So those are the proposed mechanisms that researchers are looking at, trying to find a way to treat stimulant use disorder. So research into medications for stimulant use disorder has been pretty disappointing. I think we've seen even as the rates of overdose and rates of use have increased. Some medications have been studied showing some modest efficacy for treatment of specific groups or people or certain disorders. So mirtazapine, which is an antidepressant, has been used to treat methamphetamine use and dependence in a population of men who have sex with men. Methylphenidate, which is a prescription stimulant used to treat ADHD, has been studied in methamphetamine use and dependence. Topamax, which is an anticonvulsant, and also maybe some of you recognize this as topiramate as a headache medication, has been used to treat cocaine use disorder. And then opioid antagonists, what we're seeing is that the opioid system may be involved or have implications in other substance use disorders. So naltrexone, which is an opioid reversal agent, and naltrexone plus the antidepressant bupropion have been shown to have some modest benefit in reducing methamphetamine use. None of these medications have sufficient evidence to be recommended across the board at this time, and so more research is really needed in this area. Now we're going to look at the study of mirtazapine for methamphetamine use disorder. And this study was done in a specific population of cisgender men and transgender women who have sex with men. Mirtazapine, like we just talked about, it's an FDA antidepressant involved in the release of norepinephrine, serotonin, and dopamine. They're those neurotransmitters we've heard a lot about in the reward pathway. This was a double-blind, placebo-controlled, randomized controlled trial, and patients either received mirtazapine 30 milligrams or a placebo for 24 weeks. They also included 30 minutes of cognitive behavioral therapy or motivational interviewing per week. And then the primary outcome was looking at urine test results for methamphetamine at 12 and 24 weeks while they were still being treated, and then at 36 weeks, which was after the treatment ended. And this graph shows the results. And so there was a significant reduction in the number of urine samples positive for methamphetamine at 24 weeks. You can see mirtazapine is the yellow line, and then the placebo was the blue line. But there, and this persisted until 36 weeks. So there was a reduction, but there was really no difference in abstinence between the groups. One of the secondary outcomes from this study is that they saw a significant reduction in some sexual risk behaviors at 24 weeks. So there was a reduction in number of partners and a reduction of condomless anal sex. So those were, while these patients were treatment seeking, they also improved some of these other harm reduction strategies. So the other study that we're going to look at is Bupropion, which is an antidepressant that's got some stimulant-like properties, and it acts on dopamine and norepinephrine systems, which, remember, those dopamine and norepinephrine neurotransmitters are involved in large amounts in methamphetamine use and cocaine use. And using Bupropion is thought to decrease the dysphoria or the bad feelings from meth withdrawal. Again, naltrexone, in combination with naltrexone, which we said we feel is somehow the opioid system is implicated in other substance use disorders in the reward pathway. So that's been used to decrease reinforcing effects of alcohol and also reverse opioids. The combination of these two seems to be effective for some people to reduce methamphetamine use, and we'll take a look at that. So this was a recent study that looked at oral bupropion plus intramuscular naltrexone in methamphetamine use disorder. And this was done at multiple sites. It was a double-blind, two-stage placebo-controlled trial. And this was a two-stage trial in which people either received the naltrexone plus the bupropion, the treatment group, or a placebo. And again, to see how well this worked, the primary outcome was to look at negative drug screens during the last 2 weeks of each stage. So in the first stage, the naltrexone bupropion group, about 16% of those patients had 3 negative drug screens, while in the placebo stage, only 3.4%, or in the placebo group, only 3.4%. This was an interesting study. In what they did is the people who received that placebo in the first stage underwent re-randomization in the second stage and were given naltrexone and bupropion in the second stage. And so this is a little graph that depicts that the number of methamphetamine negative urine drug screens in stage 1 versus stage 2. So we can see that that the number of negative drug screens, both in stage 1 and stage 2, there was a higher number of people who were able to maintain that abstinence over those week visits versus the placebo. And so what they did is they took all of this data and pooled it. And after weighing and combining the percentage of responses across the stages, the overall weighted response was that people who received naltrexone and bupropion were 13% of those patients were able to maintain abstinence across those drug screens, while those who received placebo, only 2.5%. So there was a modest benefit. It'd be great if we got a number up around 30 or 40 or 50%, but This study was one of the first studies to look at this combination, and it's going to need to be repeated to see if we can get more results, or if this is something that could be really beneficial going forward. I have used it in a couple of my patients with some success. Moving on from the medical standpoint, SAMHSA developed an evidence-based resource guide for stimulant use disorders, and they reviewed studies and found strong evidence to support the following interventions. So motivational interviewing, contingency management, community reinforcement approach, and cognitive behavioral therapy. And I know most of us are probably familiar with motivational interviewing and cognitive behavioral therapy, but I'd like to discuss contingency management and the community reinforcement approach. So what is contingency management? In contingency management, there's a behavioral intervention that's designed to promote desired behaviors by providing positive reinforcers or providing rewards when the target behavior is achieved. So in the clinic setting, this could be when patients receive negative drug screens, or when patients come to all of their appointments, they may receive a positive reward, maybe more telehealth appointments, or positive affirmations, or some sort of something of monetary value. In the community reinforcement approach, we take this behavioral intervention, and this focuses on the management of the behaviors related to the substance use. And so we're going to help patients create and adopt a more pleasurable and rewarding lifestyle that's going to involve family, friends, job, etc. And what we hope is that this new lifestyle that we help the patient create is more rewarding than the lifestyle they had when they were using substances. Again, contingency management, it's difficult. It's difficult to do it's difficult to have practical use in our clinical setting, but this is how it could work. We're going to use incentives again to enforce positive behaviors. So what kind of behaviors might we want to reward? Attending therapy sessions, attending medical appointments, drug screens negative for stimulants, or medication adherence. And studies have shown a couple ways to do this. There was a fishbowl method where patients were able to draw a token from a fishbowl for a chance to win a prize of varying value, say if they had 3 negative drug screens for stimulants. Another way to do this would be vouchers, where patients earn vouchers for completion of desired behaviors, with the level of vouchers increasing according to a schedule. One way we use this in my office is when patients have a certain number of reach a certain goal with their therapist, we may allow them to do more telehealth appointments so they don't have to come in the office. And additionally, there are several prescription apps being developed right now that use contingency management, where patients and the providers are able to have access to the information in these apps. And if when a patient reaches a desired goal, the physician then rewards them with a spin on a wheel that has a monetary value. Some novel technology there, but be looking for that in the future, because it's starting to be used several places in the state. So this is the community reinforcement approach. And there's five pillars or 5 aspects of this that we need to address with each patient to effectively use this community approach. And the first part is a functional analysis, and this is going to look at the patient's substance use. What's the reason for use? Is it relieving stress, feeling depressed, anxiety? And we want to know, what did they feel was positive aspect of use, and what did they view as the negative aspects of their use? The second part is relationship counseling, and this looks to improve the relationships that are oftentimes broken when someone has a substance use disorder. And we want to improve the relationship between the patient and their partner or their support system. Vocational guidance, job skills training. Really, we want to give the person the skills so they can obtain and maintain a meaningful job. We also want to focus on building social and drug refusal skills. So relapse prevention, problem solving, communication, identifying high-risk behaviors from the past, and learning how to anticipate relapse. And then the last part of this is social and recreational counseling, trying to find new activities and networks that show patients they can enjoy life without drugs or alcohol. So this community reinforcement is really building a whole system around the patient so that they choose to have this better lifestyle rather than return to use. Difficult to implement, requires a lot of it requires a lot of moving parts, as you can see. So when we're looking at these behavioral treatments, it's been really difficult to study this on the whole, because we just do not have that much research into stimulant use disorders. But there was a meta-analysis that looked at 50 randomized controlled trials, 12 psychosocial interventions, and this involved about 7,000 participants. And what this showed is that the most effective, and this was for various substance use disorders, and then they broke it down into opioids, stimulants, and alcohol. And for stimulants, what they found is that the contingency management, plus the community reinforcement approach was the most effective to help patients using stimulants maintain abstinence, and also for retention and treatment. This contingency management plus community reinforcement, those two together were more effective than just cognitive behavioral therapy alone. So part of treating a stimulant use disorder, or any substance use disorder, is going to be harm reduction and overdose prevention. And when you have a person patient in your clinic, it's an opportunity for varying levels of prevention. Secondary prevention, it's an opportunity to screen and identify the disease in its earliest stages when someone comes in. It's also an opportunity for primary prevention, where we might prevent disease before it occurs, or help someone or prevent someone from developing another substance use disorder. In tertiary prevention, this is managing the disease after diagnosis to slow or stop disease progression. Our opportunities for tertiary prevention is being able to treat hepatitis C, HIV, or other chronic illnesses when our patients with stimulant use disorders come in. So the CDC identifies that patients who use injection drugs are highly likely to develop the following infections, including HIV, hepatitis, endocarditis, injection site infections, sexually transmitted infections, and tuberculosis. So we want to treat these when we identify them, and we want to try to prevent them if the patient comes in and does not have any of these. So reducing risk of injection during active use. Counseling patients on safer injection practices may reduce the spread of disease. So the CDC recommends don't share equipment used to inject drugs. We want to always use new sterile needles, syringes, and prep equipment. Set up a clean surface. Don't divide and share drug solutions. We want to wash hands and clean the injection site with soap or alcohol prior to injecting, and we want the person to only handle their own equipment. And I talk about this risk reduction method with people who even don't use IV drug use, because we never know if that opportunity is going to arise. So hepatitis B, we want to talk about methods of harm reduction, and hepatitis B is not curable, but some treatment exists. However, damage to the liver typically occurs faster when people have multiple types of hepatitis. So we want to encourage patients, if they have hepatitis B or C, to go ahead and get immunizations for hepatitis A and B. Also want to encourage safer sex practices, consistent and correct condom use. For patients with HIV, we want to encourage them to adhere to their ART therapy. And for those HIV negative populations, we want to identify if PrEP is something that would be beneficial for them. For our patients with substance use disorders, we want to do regular screening for HIV, hepatitis C, and STIs. And this is an opportunity to discuss the transmission of these diseases and how patients can help prevent transmission. We also want to, I know I don't have to tell anyone on here, but overdose prevention always involves Narcan or naloxone. I think it's very okay given the level of drug screens that we're now seeing of patients who are primarily stimulant users, methamphetamine or cocaine, and are now showing up in our drug screens with fentanyl and sometimes other opioids. I always provide naloxone to these patients while counseling them. This will not reverse a stimulant overdose, but at the same time, we're seeing so much concurrent use that it's a good idea for people to have naloxone. And then one of the most important things we can tell people is counsel the patient never to use alone, so that there's someone who can call for help. So just as we wrap up, I wanted to take a minute to discuss barriers to comprehensive treatment for patients with stimulant use disorders and mental health conditions. PCPs are often frontline for mental health treatment. Specialty mental health providers often only see the sickest patients, and a lot of times substance use disorder treatment occurs in a completely separate system. So one of the barriers to treating the patient as a whole is a lack of healthcare delivery systems that provide comprehensive primary care, mental health, and substance use disorder treatment. And the clinic that I work in, we have now combined all three of these things, and we're seeing great improvement in health, being able to deliver all of these in one area. Admissions to treatment centers demonstrated that patients with co-occurring methamphetamine use and opioid use, so both, were 35% less likely to have MOUD as part of their treatment plan. We also know many substance use disorder treatment centers do not employ clinicians or do not allow medication for substance use disorders or mental health conditions. And then an estimated 45% of individuals in state and local prisons have co-occurring mental health conditions, and adequate treatment is lacking for mental health and substance use disorder in the criminal justice systems. So in summary, stimulant use disorders are difficult to treat and often involve off-label use of current prescription medications, behavioral interventions, and harm reduction. The community reinforcement approach and contingency management are effective evidence-based behavioral interventions for stimulant use disorder. And the rise in hospitalizations and overdoses involving stimulants demonstrate that stimulant use is a growing problem in the US, and it's imperative that the community reinforcement approach and contingency management are incorporated into more treatment programs, and that we continue research into medications that may help with stimulant use disorder. I think I will save the case discussion for our for next week, but does anybody have any questions or comments? Happy to hear comments as well.
Excuse me. It looks like we have one question
Okay.
From the chat that says, what does an overdose look like with stimulants only, or is that possible?
Yeah, so stimulant overdose is possible, and we talked about some of the it may be hard to define what a stimulant use overdose looks like. What we commonly see is that there are physiologic processes that occur when there's the risk of a stimulant overdose death. The person may be showing signs of a heart attack, signs of a stroke. They may have a seizure. All of these reasons, chest pain, really high blood pressure, heart rate that's really high, stroke symptoms where people might have facial drooping, they're not talking, you can't really understand what they're saying. So signs of other major medical conditions could be identifying that a person is having an overdose from stimulants. When we think of that compared to opioids, we think a lot of the mechanism of action of the opioid overdose is oftentimes respiratory depression. That doesn't typically happen with stimulants. It's more the danger of developing one of these other conditions.
There's a question from Shirley. You can unmute yourself.
I just had a comment I wanted to say. First of all, thank you for all this knowledge, but I never knew the difference with cocaine and methamphetamine and what their mechanism of action was as far as the dopamine. So I'm certainly glad that you explained that today, because I'm thinking they're both speed, but I did not know why. I mean, of course, people get addicted to cocaine just the same as meth, but the euphoria people feel off methamphetamine is just astronomical. And now I understand that. So thank you for explaining that. I had no idea.
You're welcome. You're welcome.
I'll just make a quick comment about one issue that came up earlier. So there was a question around sort of Suboxone and stimulant use disorder. And in general, we should not be using Suboxone when somebody does not have an opioid use disorder. So I would use extreme caution when hearing sort of stories about that. And at the same time, somebody with both an opioid use disorder and a stimulant use disorder may benefit from Suboxone significantly when, especially if they're using the stimulants to augment sort of the use of their opioids or to minimize withdrawal symptoms. Suboxone is going to help with that. It just might require more close follow-up, additional help and support for that individual. So if somebody has both a stimulant and opioid use disorder, really trying to get them into treatment with those medications for opioid use disorder that improve mortality, so methadone and Suboxone is going to be the right way to go. And as clinicians, we can sort out what else might be helpful to support their recovery from stimulants.